Charles Johnson. Yes, I'm here to talk to you about the role that the nurses have in selecting an information technology system. Yes, and today I'll be talking about how everything we do as nurses on paper years ago we now do in the EHR. And that's how we play a role in selecting the information technology system. In the 1800s, they said, the stethoscope, they said this would not take off. This was too advanced for a nurse to use. Now we're better educated. We have more education. Nursing school's a little harder, I guess. And we are able to play a role in implementing a new information technology system. The first thing we do as nurses usually is patient care. Okay, as nurses, we're on the clinical side, and we've talked recently about the administrative side, the clinical side. All hospital systems, the two sides of the hospital system. The administrative side are the side that does not involve direct care. We're going to be talking about the clinical side, or how the nurses play in the clinical side, how we help influence a healthcare system. Now, the first thing we do is patient care, and one of the first things we have to do is make sure our patient is alive. That's vital signs. Vital signs are taken by a nurse or a nursing assistant, and they are placed into the computer, and it allows the nurse to go ahead and look and see if the vital signs are within normal limits, as we say. Now, when the vital sign is high, we can see that maybe a medication as needed is currently needed, because the vital sign, the blood pressure may be 170 over 75 or just high. And at that point, we can use hydralazine or clonidine or whatever the doctor has ordered on the MAR. And we'll be going over that too, and how that has played a role. Well, first off, the vital signs is something we look into the patient. We can look at a patient's history and physical, because it's put in our chart, and we can look at it. So we need this information. We need everything that is in a patient's big chart in the EHR. We have big binders often in the hospital for each patient, because we need the paper charting just in case the EHR systems go down. But currently, we do not put, physician orders. We no longer have to write those out and do telephone orders and have the doctor sign it at a later time, because now the doctor has access to the EHR that we have access to, and we acknowledge the change of order. So if a doctor enters a new medication, we'll get that a red alert, a yellow alert actually, on my EHR, and it will tell us, hey, we need to acknowledge that the patient has a new order, rather than the doctor leaving the whole chart in the doctor's room, and then we're going to pick it up, and the order not being carried out for over 2 or 3 hours, and somebody's getting in trouble that day. Now, when we give a medication, which is a very important task, we often go in a patient's room, we scan, and we know the patient's name at that moment. We look at the armband, we scan the armband, their name comes up, and we have our medications with us, because we have a MAR also. We also print a MAR. But the EHR, it saves time. Because recently, before there was an EHR, we still had 5 to 6 steps. The right time, the right dosage, the right patient, the right medication, the right route, and the right documentation came about. But now we don't need that anymore, because our scanning and our medication, when we scan that medication, if it's the wrong medication, it'll beep. So now we know it's the right medication. If we scan a medication that says 40 milligrams of simvastatin, and we have a 20 milligram pill, it'll ask one of two, because it knows pharmacy only has it available in 20 milligram tablets. So it will ask you, where is the other 20 milligrams? So you have to have all the medication there. You scan it correctly. It'll let you say, I given that medication. And then at that moment, you would then give the medication the proper route, whether it be crush it or some patients take it PO. But even the EHR will tell you how to give that medication. PO, nasal gastric tube, and you got to make sure this information is being updated on a regular basis. Now, this is some of the downsides of a EHR, because I've gone into a patient's room, I've read a MAR on the EHR, and it said, give patient by nasal gastric tube. Okay, well, I walked into a patient's room and looking for a nasal gastric tube or a G tube in the stomach. There was no stoma and there was no nasal gastric tube. So the one of the drawbacks is you must make sure that the EHR medication record is updated often, because oftentimes they take out the nasogastric tube for whatever reason, and the patient has now done a swallow study from a speech therapist from another provider, and no longer needs a nasogastric tube and taking his pills whole. And this is why we still need that word of mouth, that word of mouth from the previous nurse that had the patient. But getting back to why we play a major role in the health systems implementation is because we also know that when we give basic care, turning and positioning, because turning and position is very important, because you got wound care, and wound care, when a patient lays on their backside too long, their skin starts to break down. Well, in the work list in the computer, you will see that you need to turn the patient from the left side to the right side to the left side. Perineal care is done. A bed bath is done. It lets you list everything that you've done as far as the ADLs, the activity of daily living, is right in the EHR. And again, everything you're able to do on paper charting, you must be able to do on the EHR. So you don't need to go ahead and rely on paper charting. We're totally trying to implement a EHR for the nurse. So now here we are as nurses, and we must stay in ratio. So if I'm on tomorrow night, I know that I'm a med-surg nurse. Typically, I do telemetry, but I know that you get 5 patients for med-surg and 4 patients for telemetry. Well, the staffing, the operation manager, strategic management needs to also have access to this information, what the census is. So the census of 15 on one station or 20 on one station. You know, you need 5 nurses. I mean, not 5 nurses, but 4 nurses for 20 patients. So you need on a med-surg floor. If you have telemetry, you would need 5 for the same, because you can only get 4 patients in telemetry as versus 5 patients in med-surg, 2 patients in ICU. Yeah, and oftentimes you have to know the staff. EHR allows you to know the staff because it allows you a program. They know that I am an LVN. And oftentimes, as an LVN, I will not have a patient on a heparin drip. I will not have some of the more complex case loads. I have a lot of complex case loads, but not heparin drip and not new emissions. They also know to pair me with somebody that may not have so many IVs or a lot going on, because as an LVN in my facility, I have to get the RN to do my IV pushes, or somebody else to do IV pushes and hang my piggybacks. So basically, everything that I need to do on paper, and not just me, but all the nursing staff, we need to be able to do in this EHR, from scheduling, any direct care, any direct contact that we have with a patient, we need to be able to make a update to the EHR into the system. I's and O's is important. Inputs and outputs, weight gain, how many liters they took off during dialysis. All this has to be updated. So our role is always affecting the EHR implementation. We have iPads and different tools and phones, pagers, because we need to know statuses. We need to know the O2 stat, the heart rate. All that can come right to a phone, and that's an EHR. So when you're implementing an EHR, a nurse role is basically their direct care. So everything they're able to do on paper, they must be able to do when oh, my computer went out there for a minute. Well, that's all for me. I just wanted to read a quick little verse from Florence Nightingale. It says, "May we hope that when we are dead and gone, leaders will arise who will have been personally experienced in the hard, practical work, the difficulties and the joys of organizing nursing reforms, and who will lead far beyond anything we have done." And that is really a big thing, because as we go on, we are only going to improve on nursing, because a care will improve. They find new ways to implement more ways to improve the quality of care. That's what we're really about, is improving quality of care and making sure patient satisfaction and patient care is carried out. And that's how nurses play an impact on the EHR. And that's very important, because it's more important than anything is patient care, advocating for your patient, looking after your patient, and making sure that the patient, you've done everything you can do to prevent the patient from dying during your shift. And if you have a pager and that's connected to your EHR that tells you the patient is heart rate has went up to 130, or they're or down to 30, or whatever it may be, it's up to the nurse to implement that and use it to their advantage, and hurry to the patient and find out what's going on, and maybe collaborating with the respiratory therapist, and because we work with other disciplines as well, and the nurses play a good role in implementing or selecting a EHR or health information technology system, and that's what we do. And this has been Charles Johnson, and if you have any questions, you can reach me at charlesjohnsonlvn@gmail.com. Thank you.